Okay, so we're going to go ahead and get started with our next talk. Our next speaker is Ravi Raju. He started medical school at Baylor College of Medicine in 2006 after graduating from Harvard College with a dual degree in chemistry and anthropology. In his first year, he traveled to Santa Ana, Honduras, with the Baylor Shoulder to Shoulder program and has since served as a member of their board. After his second year of medical school, he worked on a Gates Foundation project studying the inefficiencies in maternal and neonatal health care in India. He then enrolled in a PhD program at the Harvard School of Public Health, where he worked on developing novel therapies for the treatment of multi-drug resistant tuberculosis. As a third-year medical student, he has resumed his work with Baylor Shoulder to Shoulder and hopes to help the organization achieve its goal of long-term sustainable health care delivery in rural Honduras. Please welcome Ravi Raju as he shares his experiences on practicing global health as a student, opportunities for grassroots involvement with Houston Shoulder to Shoulder.
All right, guys. Oh, does this have a laser pointer? I don't know what I just did, but I thought I was trying to point. So, there we go. So thank you for the introduction. As I said, my name is Ravi, and I'm currently a third-year medical student. And I've been working with Shoulder to Shoulder since I was a first-year medical student back in 2006. And as I say that, I'm just now realizing that it makes me sound like a very delinquent medical student. But I've taken a lot of time off. And what I'm going to talk to you today is about the work that Shoulder to Shoulder is doing in Honduras and sort of put it in the context as all of us being sort of trainees and sort of getting our feet wet in global health and how we can help out and come together in a holistic way. So just a brief outline of my talk. I'm going to start by giving you a brief history of the foundation, talk about the expansion of the program. It started in 2001, so it's been in operation for a little bit over a decade, and then finally close with a little bit of a commentary on how global health organizations can interact and use the passion and energy that trainees bring to the table. So there are a couple people at this conference that are actually from Honduras, so they could probably talk with a little bit more knowledge or a lot more knowledge and insight than I could about the country. But suffice it to say that the Honduras country profile on the BBC World News website starts with this quote, which reads, "Military rule, corruption, a huge wealth gap, crime, and natural disasters have rendered Honduras one of the least developed and least secure countries in Central America." And here you can see on a map of the Central American isthmus that Honduras is one of the countries that spans the entire isthmus, has an Atlantic coast and a Pacific coast. And as a result, with a large sort of Atlantic coast, is sort of victim to frequent hurricanes, as well as violence and crime associated with the growing drug trafficking that kind of cartels use to pass drugs from South America to Central America. And just here is one picture of the devastation that these natural disasters can have on the landscape. So this is a rural town in the lowlands of Honduras that was devastated after Hurricane Mitch in 1998. Sort of taking a 20,000-foot view of Honduras, what are we looking at? The Human Development Index, which was pioneered by Amartya Sen and several other economists to look at development at a global scale, sort of uses three metrics to characterize how well developed a country is: life expectancy, the mean number of years a child spends in school, and the gross national income per capita. And as you can see, Honduras, which is here in the light blue, falls in almost the bottom rung of all countries in North and South America, where a child only goes to school for about 5 to 6 years, and 50% of the population lives under the national poverty line. So it's sort of in this context, and I know this was a very brief 20,000-foot view of Honduras, and I apologize for the gross overstatements, but it's in this context that the Shoulder to Shoulder began its work in 2001. And in its inception, the Houston chapter was founded as this biannual brigade with the dual mission of first and foremost addressing the needs of an underserved community in Santa Ana, Honduras, and the surrounding villages. And secondly, providing an international educational opportunity to Texas medical students, residents, and faculty in truly an interdisciplinary setting. So each brigade was composed of both people from the medical side, dental, optometry, nursing, and public health to really tackle the health needs of this community in an interdisciplinary manner. And what people don't realize is that the Houston chapter is actually one branch of what is a larger international organization that comprises of several universities and their departments of family and community medicine, partnering with various kind of rural communities in Honduras. So where is it that we work? So if we go back to the map of Honduras here, Santa Ana is on the western frontier with the border of El Salvador. And Honduras is an interesting country because there's inter-country variability. So you have the financial and the governmental capital, Tegucigalpa, which is right in the south-central part of the country. And then you have the large Atlantic coast that has a lot of touristry and sort of development around that to support the scuba divers and surfers and backpackers that flock to Honduras. But the western part of the country has been largely neglected politically because there's been frequent border disputes with Guatemala and El Salvador starting from the turn of the 20th century, as well as physical remote kind of isolation. There are several mountain ranges that pass here that sort of isolate the western frontier from the rest of the country. And this is what this landscape looks like. So this is actually on the way to Santa Ana. You can see here a dirt road that descends into the valley to a riverbed down below where the village actually sits. And what should be, by the crow flying, about a 2-hour drive from the capital ends up taking about 8 to 10 hours because you're climbing and you're descending into valleys and mountains where there are literally no roads, and you need 4x4 vehicles. So that's actually me in a vehicle in front of another set of brigade members going down this road into Santa Ana. And what do you see when you get there? So this photo was actually taken in 2001 with the 1st Brigade. And Santa Ana is a sleepy town, about 700 inhabitants, but the surrounding area has a larger catchment area of about 14,000 people. And as I said, this area has a history of being isolated. When Shoulder to Shoulder first started working there in 2001, there was no electricity, no water, no phone service, no continuous medical access. The nearest hospital was 5 hours away. But they did have a small health center that was built by the Ministry of Health, but was actually only staffed about 50% of the time by a nurse that would sort of migrate between different health centers. So it was in that context that these brigades started doing their sort of biannual work. And in one of the first brigades that went, the decision was made to create an equal partnering community-based board on the ground that would be able to interface with the members of Shoulder to Shoulder and sort of come together and talk about the needs of the community and how we can help. And one of the things that quickly emerged in this partnership between community members, both from Santa Ana and the surrounding villages and the Shoulder to Shoulder faculty, was that a brigade wasn't enough. A mission trip that went twice a year was basically a temporary stopgap to addressing the multitude of problems that these people were suffering from. And so in addition, the community leaders and Shoulder to Shoulder got together and pioneered and highlighted 3 areas in which we could sort of come together and work towards a sustainable healthcare development model. The first was advocacy. As I talked about, and you saw from that picture, there was no electricity, there were no paved roads. It was really hard to get to Santa Ana, and as a result, this community was isolated. So we talked about advocacy leading to government investments in the development of the region. Secondly, recognizing that brigades aren't the ultimate answer, there was talk of establishing a permanent clinic with inpatient capabilities that could lead to kind of acute care being permanently available in this region. And lastly, realizing that acute medical care is only one component of overall health of a population, the community was extremely excited about various public health projects to increase health literacy and to increase the practice of preventative medicine. So going through each of these, what has the progress been over the last decade that the organization has been working there? So this is the same square taken when I went the first time in 2006. And you can see here that a lot has changed. You can see electricity wires now crisscrossing the main square. You can see that there's paved roads that lead into the town square. The mountains, though, are still another story, and those have not been paved. But that being said, they have water, they have paved roads, at least locally, and electricity, which has allowed us to really kind of think about development in a whole other level for the people living in Santa Ana. And secondly, the second thing that was highlighted was establishing a permanent presence. And this was actually a picture taken 2 weeks ago. And I'm happy to report that a full clinic, a 2-story clinic with inpatient capabilities is about to be launched in July of this year. And so over the last 5 or 6 years, there's been aggressive fundraising, and the clinic and hospital will be open in July, fully accepting patients. On the front side of this, there's actually a sort of makeshift clinic that's actually been operational for the last 6 months, and we've hired a local Honduran doctor, Dr. Carol Gomez, who is seeing patients sort of in an outpatient setting, at least temporarily, until the clinic fully opens. And lastly, this is where I'd like to focus a little bit of time on recognizing the importance of public health projects to increase health literacy and access to preventive medicine. Each brigade that goes down now, each brigade twice a year, is tasked with sort of continuing a public health project or championing a new one in order to help the community in addition to the direct medical services that are being sort of offered by the community. And so while there have been about a dozen projects that have been sort of tossed around over the last 10 years, I'm going to focus on three: childhood nutrition, home ventilation, and home education, and talk a little bit about each one of those. So childhood nutrition, that's actually my hand, and I had a lot of fun sort of collecting anthropomorphic data with the kids that I was working with when I was there in 2008. So what is the problem? These are students, and I'd like to point out in the theme of my talk, which is how do trainees interact in global health, all of the research that I'm going to be presenting to you today is by students. These are students that went down with doctors, with PhDs in public health that said, hey, I have this idea, I want to see what's going on in Santa Ana, can we do it? And the board and then the members of the organization have said, yes, if you bring the passion, you can do it. So these were two students that in 2005 did a comprehensive assessment of what are the nutritional needs of the children living in this community. And what they found was quite interesting. They found that most people in Santa Ana, 95% of what they consume boils down to corn, rice, and beans, leaving a significant gap with respect to micronutrient deficiencies, specifically vitamin A, iron, and iodine. And they backed this up with some anthropomorphic and blood sampling. They took a representative sample of children in Santa Ana below the age of 5, and were actually able to show that 34% of children suffered from stunting, which is a low height for age ratio, and up to 30% of children were suffering from some form of mild to moderate anemia. So armed with this knowledge and this research, what do we do about it? The first iteration of how Shoulder to Shoulder wanted to tackle childhood nutritional problems in Santa Ana was the development of an infant feeding cereal program that targeted 6-month to 2-year-old children, which were deemed sort of the most vulnerable age group where these sort of micronutrient deficiencies can take their toll. And there was an organized attempt by the mothers in the community to create a fortified cereal feeding program where fortified cereals were brought in from Santa Ana and children were fed 3 times a week, and specifically targeting the micronutrients that were found to be deficient in these children. So after 2 years, we went back, and this is now when I was there, and we did a little bit of a follow-up to see if this program was actually working. So we repeated some of the anthropomorphic data, we repeated some of the blood sampling, and to be quite honest, we were a little disappointed. So first and foremost, the fortified cereals were rather expensive. Nestle was not being gracious in their donation of the cereal to our program. Secondly, we found that there was not enough cycling of these children. So the program had lasted for 2 years, and we were finding that the rates of new enrollment were markedly less than what we wanted them to be. And finally, the stunting rates were actually statistically not significant from 2 years prior, comparing children that were enrolled in the program and weren't enrolled in the program. And this was an important moment for us, and I think it was one of the talks over lunch, I think it was the water talk. I think one of the things that we don't do enough in public health, and I'd like to do more with the work, is sort of analyze the failures that we've had and sort of understand how we can grow from those failures and understand how we can succeed better. So looking back on this failure, what we found and analyzing the roots of why this program had not been as efficient and effective as we hoped, we took a few lessons. First, a positive from our experiences, we had positive affirmation that data collection and research is essential to the success of public health projects. We wouldn't have known that this was not working had we not collected the data both before, during, and after. And finally, self-sustainability and self-empowerment must be stressed. So basically, in this flight, we realized that sort of shipping in these fortified cereals is not a long-term solution to empowering children and figuring out and solving their nutritional needs. And finally, community involvement and education are crucial in development of this initiative. So with those sort of knowledges and nuggets under our belt, we started to think about other ways in which we could kind of empower childhood nutrition. And on our visit, we were extremely impressed with the fact that a few families had kind of these immense, massive gardens where they were growing things like pumpkins, bananas, and peas that sort of as a collection would sort of basically reduce the micronutrient deficiencies in those families. And so we've tried and pioneered an initial kind of study where we took where we take these kind of families that are already sort of engendering these practices with community and family gardens and have them lead courses and teach other families in the area and to see if they can actually be dissemination of this knowledge throughout a larger percentage of the community. And we still haven't completed the data, but we're hoping to see that what this can lead to is a self-propagation and sustainable expansion of available access to a diverse foodstuff. And I think I'm about to run out of time. So I think that I'll leave the Who's to Stove story for another day and close with sort of some commenting on the role of trainees. And I know in public health and medicine, people like to throw out their pyramids and their triangles. So I thought I would take a stab at trying my own. So this is my pyramid. I have no idea if this has been done before, so I apologize if I'm plagiarizing people's previous work, about looking at how to develop effective and sustainable global health community partnerships. I think we all recognize that clinical care is paramount. We need to be providing clinical care to kind of deal with the pathology that we're seeing in a community. But in addition to that, these efforts need programmatic support. They need fundraising. They need sort of logistical underpinnings to know how these programs are going to run. And finally, there's an active component of public health and development in order to understand what the larger community needs are. And underneath all of this is a foundation of research. And at its root, research is asking, how can we do things better? You can do research in public health, in clinical care, and in programmatic support to learn from the mistakes that you've made and know what to do in order to succeed in the next iteration. And where I think trainees who are not medical staff or trained and at a professorial level in the academic setting can help out is really in this public health and development and programmatic support stance. And in that vein, Shoulder to Shoulders, we are actively considering and pursuing research, and we've actually been fortunate to have students who have been able to take to completion kind of some studies that they've done on the ground while in Santa Ana during their time. And for interest of time, I'll just briefly state these, but actually some students at the UT School of Public Health, Aaron and Joseph, along with some faculty members, were actually able to help us improve how we were collecting our anthropomorphic data and how we were interpreting it. So we actually ended up catching more people that were suffering from stunting and malnutrition and able to enroll them into the programs that we were envisioning. And finally, this is an interesting anecdote from another study that was done. There was a lot of talk early on in Shoulder to Shoulder about importance of childhood vaccination and saying we need to invest a lot of money in sort of vaccinating children. And so someone asked the question, well, what is the baseline rate of vaccination in rural Honduras? And what we found was while horizontal health care was abysmally poor in this region, the government was actually very effective at running these spearheaded vertical programs at vaccinating children in the most remote areas you could ever imagine. So that rural vaccination rates were actually comparable to vaccination rates that you could find in Tegucigalpa. And what this allowed us to do was save the spending of unnecessary money towards vaccination programs and telling people to get vaccinated, because we simply found out that that would be money that would be just duplicately being spent since the government was doing such a good job of it. So I think in closing, I'd like to just say that I think trainees and people who are interested in research and service can really synergize with a lot of the clinical care that are being provided by mission trips, by NGOs, by sort of asking the simple question, how can we do what we're doing better? So with that, I'd like to close and just acknowledge this kind of conference and how it's bringing together people that are doing lots of exciting work and all of the people involved to Shoulder. Right here is pictured Dr. Parkinson, who's actually the founder and the president of the organization, and I owe him a world of thanks for sort of involving me as an idealistic 22-year-old who didn't know anything about global health or public health and allowed me to sort of launch this career. So thank you guys, and I hope I have time for a question or two if you have them. Yeah.
I'm wondering with all the research that y'all done on, do you take a look at like or like treating
Yeah, that's really interesting. So we haven't actually researched that, but we do on the brigade trips, and Dr. Gomez, who is now practicing full time, we do sort of routine deworming of children, sort of based on the empiric data of so many other studies that have shown that it actually helps. But we haven't actually done the studies ourselves. It seems like such a cost-effective therapy to just sort of empirically treat in this region, but that's a great point. Thanks, guys.